So today we are going to talk about the pituitary gland and the function of the gland. You learn in physiology that the pituitary is going to orchestrate the all endocrine organ. The endocrine organ that secretes some target hormone that regulate the basal effect of certain cells, and that's be orchestrated by the pituitary gland. You know that the pituitary is going to release some is called trope hormone that be the regulator of the target glands. And the pituitary is regulated from the hypothalamus by affected by some releasing hormones or factors and from the central nervous system as well. So if you do have any kind of stress situation, any kind of emotional changes, that's going to influence our endocrine system. Now, talking about the regulation, that we do have certain endocrine organs, such as the endocrine gland, the thyroid gland, the testes, the sexual organs and ovaries, the breast, and the basic gland and liver. And these are be affected by these hormones. So today we are going to talk about only the pituitary and the diseases that influence the pituitary gland. Generally talking, you already had some practice about it. When we talk about the diseases, usually the term is a little bit different from the general term. In general, the primary disorders usually meaning that we do not know the underlying cause of the diseases, but itself, for example, primary hypertension means that the patient has an elevated blood pressure, but that is not correlated to any kind of other diseases. When we talk about the secondary diseases, usually the secondary be the clinical signs, such as for secondary hypertension due to a Cone syndrome, it meaning that we do have a mineralocorticoid excess that caused by the release of mineralocorticoid by the adrenal glands, and this is why we do have hypertension. Talking about the endocrine disorders, primary includes the target gland. So if you do have primary disorders, that meaning the gland itself the cause of the elevated or decreased hormone production. The secondary, looking at the regulatory system, usually due to the pituitary problem or those hormones that regulates the target gland. Talking about, for example, the secondary mineralocorticoid excess, this cannot be the pituitary origin because if we do have a renin secreting tumor, that will influence the adrenal gland. So that's be the secondary. Or when you had the calcium and phosphate, the secondary hyperparathyroidism meant when we do have a decreased calcium level. So usually the second step of the regulatory processes. And the tertiary regulatory processes in the endocrine system usually involves the hypothalamus when we do have the altered releasing hormone secretion. Now, generally, the most common problem usually is the target gland problem, target gland diseases, and less common the secondary as the pituitary disorders, and rare one the hypothalamic disorders. In the clinical symptoms, usually the most striking clinical symptoms can be observed if you do have a target gland problem. Other thing, the secondary one, usually the clinical symptoms are not so striking. And the hypothalamic one relatively is causes the less clinical symptoms. Now, the pituitary sitting in a dedicated position in the cella turcicae, that's good and that's bad at the same time. It's good because it's very well protected by the bunny socket, but it's bad because it cannot expand. So any kind of edema, any kind of enlargement that occurs in this pituitary, the tissue itself, that will cause compression and that can damage the pituitary, let's say the healthy part of the pituitary gland. Now, another thing with a clinical aspect or the clinical sign, it should be considered that the pituitary, above the pituitary, sitting the chiasma, the optical chiasma. And if you do have any kind of enlargement, mostly the middle part of the chiasma is compressed, and this is why the patient will have some visual disturbance, such as the bitemporal hemianopsia. Now let's talk about the hormones. This is only repeating what you learn in physiology. The anterior part of the pituitary releases certain hormones. These hormones can be categorized based on the origin of the hormones or the chemical structure of the hormones, such as, for example, the corticotrope-related peptides that include ACTH, lipotrophin, and MSH or endorphins. The somatotrope hormones, that mostly the peptide, includes the growth hormone and the prolactin. The glycoprotein hormones such as the LH, FSH, and the TSH. The common thing in the glycoprotein hormones that we do have two alpha and two beta units. Usually the alpha is the same and the beta is changing and will influence the effect of the hormone, so targeting the hormone effect. So if you do have a very highly elevated LH FSH, can mimic the TSH action, or vice versa, the TSH can mimic LH FSH if you do have a very high level. When we do have a loss of the pituitary function, what can cause the loss of the pituitary function? It can be congenital, for example. It can be due to some pituitary tumors. That tumors can secrete some hormones, but some other, let's see, tumor are not going to secrete any tumor. However, due to the compression, usually the other, let's see, cells are compressed. So this is why the pituitary is losing the function. On non-pituitary tumors such as carcinopharyngioma or metastases or trauma, surgical or head trauma, for example, or inflammatory processes can be autoimmune diseases, some hypophysitis, or granulomatosis diseases, histiocytosis, sarcoidosis, or tuberculosis can influence the pituitary gland itself and can cause the hypofunction. When the pituitary is losing their hormone secretion, usually it has a typical progression of the hormone loss. Well, generally talking, in adult one, the most sensitive one, LH-FSH, so the gonadal hormone secretion. However, in children one, the most sensitive, the growth hormone production. And first, the losing, let's see, the growth hormone and the gonadal hormonal secretion. Later on, the thyroid stimulating hormone, ACTH and prolactin. And finally, the other part, the neurohypophysis function is lost. And this is called the panhypopituitarism. So we do have a very famous panhypopituitarism that is called Shear Syndrome. What Shear Syndrome is? Shear Syndrome is a dedicated disease that occurs after pregnancy when the pregnant woman loses too much blood during delivery, and this is why the pituitary can be necrotized. Normally, the pituitary is not taking too much blood, too much oxygen supply. However, during pregnancy, the increased hormonal level and the enlargement of the pituitary, the hyperplasia of the pituitary needs more nutrition, more oxygen. This is why it's hypertrophied, needs more oxygen. So let's be very sensitive to hypoxia. So what will be the clinical sign of this pituitary necrosis, postpartum pituitary necrosis? The lactation fails to start. And later on, other, for example, ACTH deficiency or TSH deficiency can develop. And usually after the 4 months, the FSH, LH deficiency can be observed, but you have to act right away as soon as possible and substitute the hormone milieu to the patient. Now, how can we treat the hypopituitarism? Usually, you have to remove the cause, and after you have to apply the replacement therapy and depend on the hormone loss. If we do have a problem with the TSH secretion, you should apply the thyroxine, or if you don't, if you lost adrenal adrenal gland function by decreased ACTH release. The cortisol should be administered. In growth hormone, usually administered for children to keep the linear growing, and the testosterone and estrogen replacing the sexual steroid hormones. Now, when we do have only the decreased secretion of the growth hormone, that can cause dwarfism. However, the dwarfism can be due to some other disease as well. What we're talking about the dwarfism or nanosomia, when the height of the patient is less than 147 centimeters. Now, the most common cause of these dwarfism or nanosomia, as you do see here in the picture, there's a Peter Danglage, uh, that achondroplasia, it's about 70% of the cases caused by that. This is a mutation of the FGFR receptor 3, and the 75% of children with this achondroplasia are born to the parents of the average size due to the new mutation or genetic changes, so it's not this heredited one. And the other one, there's other common one, the growth hormone associated diseases, but this can be something as some other endocrine diseases, such as a hypothyroidism or Cushing syndrome, or connective tissue disorder, such as osteogenesis imperfecta, or Turner syndrome, or stress, for example, psychogenic dwarfism can develop. So there are several types of dwarfism can develop in this issue. I'm showing you some pictures of the dwarfism that usually due to the decreased growth hormone secretion looks like it's a little teeny tiny puppets. Now, what will happen when we do not have enough growth hormone? For sure, in children, there'd be the growth retardation. However, in adult one, there is no linear growth because the epiphyseal closure occurred. So what will happen? We do have something else, such as the fat content, relative fat content is going to increase. For example, the waist-hip ratio is going to increase. The bone mass density, it will decrease, so meaning that the patient could develop osteoporosis. This is why the chance to have fracture about double, or the cholesterol, the good and the bad cholesterol ratio is changed, and that's be more heterogenic one. Insulin resistance is going to increase. This is why the patient do have an elevated insulin level. Generally, the patient is fatigued, they do have the muscle weakness, so that's be the clinical sign of the deficiency. Now, what other thing it can be? For example, associated with source statue that is depending on the growth hormone deficiency. Well, this is one when we're talking about when we don't have enough growth hormone. So that's the pituitary or hypothalamic deficiency. That's again, as we mentioned, can be acquired due to some kind of hypothalamic disorders. But it can be genetic, but in this genetic reason usually are affecting some other hormones. Usually the FSH LH deficiency also present, but relatively the monotopic is less, and its response to GHRH secretion. Now, another thing that is not the growth hormone itself is elevated, but the receptor defect it occurs. So it meaning that we do have growth hormone, however, the growth hormone cannot affect, for example, the liver and cannot synthesize somatomedin. So this is why it is called the Laron dwarfism. And the Laron dwarfism, that the genetically hereditary disease, is a very rare one. If you watch this YouTube video, you can see, for example, some area in some people that lives there, and they do have an extreme short stature, and they do have an increased level of growth hormone. However, the growth hormone receptor is missing from the peripheral tissue, and the growth hormone secretion is not altered by glucose, and the IGF-1 level is very low. Now, in this population that you can look at in this video, the incidence of the tumor or diabetes mellitus is almost none, very, very rare situation. So it looks like that the tumorigenesis or the diabetes could be connected to the growth hormone secretion. or the growth hormone effect. Another thing that the somatomedin see or the IGF-1 defects in this portion, for example, in this case, there can be the total absence of the IGF-1 or IGF-2 uh, that can be normal in the same time, that this is associated with a failure of the search of the IGF-1 that occurs during puberty. Now, this can be seen in African pigment. This is why it's called Pygmy Dwarfism. Or other thing, very rare one, when we do have the absence of the IGF-1 receptors, or we do have some kind of post-receptor defect, and that meaning that the receptor binding is all right, but for example, the induced amino acid uptake is decreased. Now, talking about the excess of the growth hormone, and I was taking this picture on a bus, and relatively this was very crowded in that time, and it looks like this patient is sitting or living around us. So when you go and when you travel any transportation system, look around and the patients are there. So I think you can figure out that this patient could have acromegaly. Now, what will happen when we do have excess of the growth hormone? Now, usually the clinical symptoms is due to the increased growth hormone and the consequently increased IGF-1. This is when it's occurring after the closure of the epiphysis that causes the acromegaly. It's relatively very rare diseases as annual incidence about 3 to 4 cases per million. So the prevalence of the 70 cases per million person. Now, the giantism, when the term is used, when we do have a growth hormone excess that occurs in children before the epiphyseal closure occurs, and generally presents with a dramatic linear growth beyond what they expected for a child's genetic potential. Now, etiology of this growth hormone excess, mostly the growth hormone producing pituitary adenoma, about 98%, and 2% taking up some ectopic GHRH secretion that, for example, small cell carcinoma or bronchial or interstitial carcinoid tumor, pancreatic islet cell tumor, or hematophiochromocytoma can cause growth hormone excess. Now, as you see here, this is the giantism, and this is the very characteristic picture of this patient who had this acromegaly. Now, there are some famous giants is right here. Let's see the highest one. This was the Robert Wadlow. There's a Wadlow the giant. As you see here, the highest was 272 centimeters. But if you go further, is still very high. Not only the man, but girls can be. So how easy one to change the ball of the light if you are only sitting it. Now, what the problem if somebody is a giant? Basically, the hydrostatic pressure is very high. Plus, the legs, I cannot tolerate this high pressure or high weight. And mostly this patient can die due to the heart problem or a vasculitis, for example. So these patients are not so strong. They look like is a big one and huge one, and you believe that they are so strong men, but they are not. Now, talking about acromegaly, acromegaly usually develops very, very slowly, and this is why the family won't consider that somebody has some endocrine problem. What picture I showed you on the bus, possible the let's say the family doesn't recognize or don't recognize that this patient has some growth hormone excess. Look at this lady, that this picture was taken in different times. It takes about 20 years to develop the full picture of the acromegaly, and very slowly the taking. So the best one, if you have a patient who had acromegaly, get some picture from the previous years, and you will see very nicely that the patient has some growth hormone effect. Now, the clinical symptoms and signs of acromegaly, usually the acral area they are going. So this is on the face, on the nose, and, uh, and the cardiomegaly can develop, barrel chest, and hyper thoracic vertebrae, hyperostosis can happen, carpal tunnel syndrome, so the nerves are compressed, increased size of hands and feet. This is why the gloves and the shoes getting bigger and bigger, and because the weight, and that can cause degenerative arthritis of the patient, and the thickening of the skin, hypertrophy of subcutaneous and the sweat gland can occur in this patient. Now look at this heart, how big? Normally the heart is around 350 grams and this patient has almost 1.5 kilograms. So for sure, this hypertrophy, it cannot uh, keep up with the oxygenation. So this patient can have some cardiac heart diseases very easily. Now, what will be the pathophysiology of acromegaly? As you mentioned, that increased growth hormone secretion mostly. And what will happen? Normally, we do have a diurnal rhythm of the growth hormone secretion, mostly the highest one in the night and the lowest one during the day. What is going to alter the growth hormone secretion? Mostly the serum glucose level. So this is why they are using the glucose suppression test. And in this patient, that is lost. So there is no glucose suppression at all. If you want to check, for example, the growth hormone secretion, whether it's normal or not, you can use a insulin test when you have hypoglycemia. That should stimulate the growth hormone release. In the opposite can be used when you do have a suspicious about the growth hormone excess. Use glucose suppression test that usually applied very similar to the oral glucose tolerance test. However, here they are not measuring the glucose level, serum glucose, they are measuring the growth hormone level. Now, some additional paradox stimulation tests, for example, dopamine stimulation test can be normally the dopamine is increases the growth hormone. In acromegaly, the growth hormone release is inhibited. And the best one to measure the serum IGF-1 level because it's very stable one, most stable one, so you don't need to have some diurnal rhythm. And insulin resistance, serum insulin level can be higher in this patient. The genetics about the acromegaly, let's talk about. There are some genetic correlation with this tumor, and they believe that could be correlated with the GPR101 mutation. They found out that the incidence it increases the presence of this mutation increases in acromegalic patient who had some tumor. So that could mean this GPR 101 mutation could be somehow correlated with acromegaly. Now, there is another disease that is called the familiar acromegaly. When is a certain family, the chance or the number of the acromegaly is higher one. Usually the familiar acromegaly occurs in less than 30 years, so early presentation. And normally, not the familiar one, it occurs usually later age, 50s or 60s. Now, individuals with a family member who has a pituitary tumor should be considered for genetic screening. Now, there are certain markers of the familiar acromegaly, for example, the Carney complex or familial isolated pituitary adenomas or multiple endocrine neoplasia type 1 also should be considered, checked genetically, and an increased awareness of the familial isolated pituitary adenomas, uh, especially it includes mutation of the aryl hydrocarbon receptor interactive protein genes. Now, what the Carney complex is? The Carney complex as a rare genetic disorder, it's an autosomal dominant condition that usually characterized with a spotty skin, hyperpigmentation, and the pigmented papules. That's a lentiginosis. And in this position, in this genetic disorders, the tumor incidence is very high, including the breast, the skin, the testes, the pancreas, the thyroid, oral mucosa cancer, for example, and as we mentioned, the growth hormone secreting tumors as well. Now, how should we treat a patient with acromegaly? Usually what we apply, the surgical removal of the tumor, and additional therapy, somatostatin analog, radiation, or growth hormone receptor antagonist could be used. Now let's look at the other tumors of the pituitary. And here is the, let's see, is listed based on the incidence. The highest incidence is called the prolactinomas. And non-functioning tumor, the 30%. So this one third, and the growth hormone secreting tumor is about 20%. So these three are the most common pituitary tumors. There are some mixed one, for example, growth hormone and prolactin secretion, because they have very similar let's see, structure. These are the somatotrope hormones, or ACTH or lipotropin. This is originated from the pro-opiomelanocortin, or glycoprotein hormones such as the LH, FSH, TSH secreting tumor. That be the less common one. Let's look at a case study. We do have a 35-year-old woman, and the chief complaint, amenorrhea. This is a secondary amenorrhea, so it meaning that she already had a normal menstruation cycle, but after a while, this menstruation stops. So this is what we call as a secondary amenorrhea, and galactorrhea, and otherwise this girl was healthy. So past medical history, nothing, family history, it's not remarkable. So physical findings, almost everything was normal, except the patient breast had some galactorrhea. You could push some uh, milk out of it. They measured the prolactin level. It was very high, so about almost 1,000 times higher than a normal value. So this patient had prolactinoma. You should take an MRI immediately, and that had a microadenoma. It's meaning the size of the tumor was less than 1 centimeter in diameter. Now, what could be the clinical presentation of hyperprolactinemia in women and men? This is the red. This is the most common sign in women, amenorrhea. So the menstrual cycle is stopping or altered, and galactorrhea. That can be headache, for example, as well. Now, in men, the decreased libido, impotence, and the patient could have gynecomastia and galactorrhea as well. In some other case, the headache, but headache is not a specific symptoms of these prolactinomas, and visual field defect, again, can be obtained in both cases in women and in men as well. How would we treat the prolactinomas? Because dopamine is regulated negatively by prolactin negatively regulated dopamine. This is why what they're using dopamine antagonist, bromocriptine, that usually normalize the prolactin level and lead to the tumor regression, and most patients with macro and microprolactinomas. The primary limiting factors are the side effect, which occurs in as many as 40% of the cases. However, the cessation of the therapy is necessary only for the 5 or 10% of patients. In this case, only the transphenyledectal tumor removal can be the treatment. I'm going to share the computer sound. Okay. No, you don't see anything. Oh.
I think the pill is the way to go. We haven't had a condom break yet, thank God, but it's bound to happen, especially the way we've been doing it.
On a bed of nails?
No, he's not kinky. He's just insatiable. I can barely make it to any of my morning classes.
You smoke?
No way.
Stop it!
Sorry.
Any history of hypertension, blood clots, strokes?
Nope. Besides my OCD, I'm fit as a fiddle.
You have OCD.
Duh. Can't you tell?
Any other compulsions besides drinking massive amounts of water?
No, that's it, thank God. My therapist says it could be a lot worse.
You get up in the middle of the night to drink?
Yeah, every couple of hours.
Well, then your therapist is an idiot. Unconscious people don't have OCD. They can't, however, have diabetes insipidus.
That's impossible. I eat candy all the time.
Different kind of diabetes. This kind is caused by banged up pituitary. You're obviously more of a lover than a fighter. I'm guessing either a car accident or you cracked your skull on the balance beam.
How'd you know?
Easy. Nice ass, no boobs. You got palms like a longshoreman. Wait here. You need a CAT scan.
Oh my God.
Don't worry. This means you'll be taking 2 hormone supplements instead of 1.
All right, so these little movies from the Dr. House, that was the diabetes insipidus with this patient. So this is connected to the ADH secretion. So what the regulator of the ADH secretion, normally the ADH release is stimulated by the plasma osmolarity. If the osmolarity increases, the ADH secretion is induced. And our any other things, for example, the hypovolemia, when we do have a fall in the plasma volume. However, emotional factors and stress, sleep, and additional factors such as the cholinergic stimulation, alpha-adrenergic stimulation, angiotensin 2, prostaglandin E2, opiates, nicotine, and histamine, or ether, or phenobarbital, they all can induce the ACTH secretion. Now, what is the diabetes insipidus? Diabetes insipidus, relatively when the patient pisses too much, but this is not as sweet. This is the opposite of diabetes mellitus. So there are two major type of the diabetes insipidus, such as the central diabetes insipidus, when we do not have enough ADH secretion by the pituitary gland. Of course, it's synthesized by the hypothalamic fat areas, and after is going to the neurohypophysis. And another one is the nephrogenic diabetes insipidus. When we do have ADH, however, this ADH cannot regulate the aquaporin if the effect. So the aquaporin cannot be uh, transfer to the membrane. So this way, it's not going to take the water. So the water permeability is cannot be regulated by the ADH. So this is what is called the nephrogenic diabetes insipidus. Now, what can cause the central type of diabetes insipidus? That's about 30% we do not know what the cause is. And additionally, can be supracellular tumors, about 30% of the cases, infections such as encephalitis, tuberculosis, or non-infectious granulomas such as the sarcoid diseases, or trauma or scar surgery, and leukemia infiltration can cause a central diabetes insipidus. What about the nephrogenic one? That can be heredited in a very mild and very small cases. And secondary can be, for example, in chronic pyelonephritis or hypokalemia, hypercalcemia, when we do have some ion disturbance. Sickle cell diseases can be associated, protein deprivation syndrome, or drugs such as lithium can cause nephrogenous diabetes insipidus. And I would add an additional one, the multiple myeloma or amyloidosis can cause nephrogenic diabetes insipidus as well. Now, it's only important thing or interesting thing. How do we treat, for example, the central diabetes insipidus? Very simple one. Let's give ADH to the patient, and ADH itself, it's resolve the problem. Now, another thing, how do we treat nephrogenic diabetes insipidus? Well, you won't believe it, but they are using diuretics, because diuretics through the increases the aldosterone synthesis and sodium retention due to the hypovolemia can decrease the amount of urine. So this way that can be the treatment. Of course, in those cases, if some kind of drug causes these diseases or sickle cells and other, you have to treat the underlying disease, and after that we solve the problem. The opposite, when we do have too much ADH, this is called the syndromes of inappropriate ADH secretion. Now, the etiology, usually ADH released is amount of far more than it should be, and this way the plasma osmotic activity be decreases. Now, what will cause? We do have a fluid retention because the patient always urinate a concentrated urine. So this way we do have a water retention. This will cause, the decrease of the serum osmolality. So hyposmolality can happen, and hyponatremia, very important one. If you look at the serum sodium concentration, that correlated with the osmolality of the serum, as you learn. So in any other changes, when you do see that the patient has a decreased sodium level, that could mean that the osmotic activity is less. Hypochloremia can happen, and as I mentioned, that the concentrated urine and the presence of the increased, for example, intravascular volume, and the patient could have hypertension. Now, let's see what else can cause these syndromes of inappropriate ADH secretion. Certain pulmonary conditions such as pneumonia, tuberculosis, abscesses in the lung, or positive pressure ventilation. If you do have some artificial ventilation or trauma, most frequently the head-related traumas, meningitis, subarachnoid hemorrhage, AIDS, Addison's diseases, peripheral neuropathies of psychosis, vomiting, stress, and symptoms may also be caused by the ADH secreting tumors as well. So these are the different causes of the CADs.